This is Andrew Coe with the University of Washington. We're going to talk today about the diagnosis and non-operative management of trigeminal neuralgia. We'll start with some key concepts. Trigeminal neuralgia is an orofacial pain syndrome characterized by unilateral, severe paroxysmal pain. These pains can be precipitated by innocuous stimuli on the affected side of the face. On the other hand, patients sometimes do have concomitant persistent pain in the same distribution. The diagnosis of trigeminal neuralgia is based purely on patient history. There are no diagnostic laboratory or imaging tests. Trigeminal neuralgia is a heterogeneous disorder. There are several classification schemes, and these have an impact on treatment outcomes. In the diagnosis of trigeminal neuralgia, there are several important factors to consider. Prior trauma to the face, herpes zoster outbreaks, and other neurological conditions such as multiple sclerosis can cause similar pain syndromes. However, while these conditions mimic trigeminal neuralgia, they often do not respond similarly to the therapeutic options that are successful for trigeminal neuralgia. Trigeminal neuralgia is rare. The estimated incidence ranges from about 5 to 25 in 100,000. It is more common in women at a ratio of about 1.7 to 1. As age increases, the incidence rises to nearly 45 in 100,000 in patients aged over 80. The cause of trigeminal neuralgia is unknown. It is often associated with neurovascular compression. However, trigeminal neuralgia can occur and recur in the absence of neurovascular compression. Anti-epileptic medications such as carbamazepine remain the mainstay of non-surgical management. Initial control of pain occurs in about 90% of patients. However, this pain relief can lapse over time, and side effects often limit utility of medications. These side effects are intolerable in up to 1/4 of patients. Surgical treatment has similar initial rates of efficacy. The durability between the different options is variable. Given what we know about the natural history of trigeminal neuralgia, the outcomes for available therapies, and the patient-centered evaluations of their treatment of trigeminal neuralgia, surgical therapy should be discussed with all patients, even though it may not be appropriate for all of them. It is worth noting that the treatment guidelines for this disease are based on relatively weak evidence. We instead rely on intuition and expert advice. Thus, efforts to develop more data-driven approaches to treating this disease are needed. We'll move on to the diagnosis and classification systems for trigeminal neuralgia. The diagnosis of trigeminal neuralgia is usually straightforward. The clinical characteristics of the pain are shown here. The character of the pain is usually described as shooting or sharp, as electric shocks. In contrast, Type 2 trigeminal neuralgia, or trigeminal with concomitant persistent pain, has a component that is described often as dull, aching, cramping, burning. Occasionally, patients also describe this as a numb feeling. The severity of trigeminal neuralgia pain is moderate to severe. It has a reputation for being excruciating and is often called the suicide disease due to the severity of the pain. Pain should be located within the trigeminal distribution, which is pictured here on the right. One should note that the V1 distribution often extends behind the hairline, up towards the vertex of the head. One should not ignore the distribution of the trigeminal nerve within the mouth as well, which is usually V2 and V3. Trigeminal neuralgia is almost always unilateral, and it almost never affects V1 alone. The characteristic pain of trigeminal neuralgia is paroxysmal. Pain attacks last for seconds and are often separated by pain-free intervals. Patients can report dull after pain after initial attacks. In the long term, trigeminal neuralgia can remit on its own, with pain-free periods lasting weeks to months. There are very characteristic provoking factors for trigeminal neuralgia pain. These include cutaneous triggers, temperature changes, and activities such as eating or drinking. Patients also report spontaneous onset, and patients usually report that sleep helps. Trigeminal neuralgia pain that awakens patients from sleep is rare. Trigeminal neuralgia can also be associated with sensory changes. More typically, there are trigger zones where cutaneous stimulation can cause pain attacks. Trigeminal neuralgia can also be associated with disorders of the temporomandibular joint. The diagnosis of trigeminal neuralgia depends on the clinical interview. However, an MRI should be performed in order to evaluate for neurovascular compression and/or rule out other diseases such as multiple sclerosis or the presence of a mass lesion. Differential diagnosis for trigeminal neuralgia can be broad. There are several disorders of the trigeminal nerve that can mimic trigeminal neuralgia. Postherpetic neuralgia, trigeminal neuropathic pain, and trigeminal deafferentation pain are often accompanied by allodynia, which can mimic the triggered pain of trigeminal neuralgia. However, these conditions often involve more continuous, burning, itching, tingling pains that distinguish it from trigeminal neuralgia. More importantly, a history of zoster eruption, dental procedures or facial trauma, or surgical treatments for trigeminal neuralgia help distinguish these conditions from trigeminal neuralgia. Odontogenic causes for facial pain should be ruled out when considering a patient with trigeminal neuralgia. Dental caries, pulpitis, or tooth sensitivity can often mimic V2 or V3 pain. Facial pain can also derive from the sinuses or salivary glands. Careful attention to the quality, location, and exacerbating factors for these pains can help distinguish it from trigeminal neuralgia. Other rare entities, such as Eagle syndrome, can involve the throat, neck, and radiate to the face. Again, careful attention to the location and quality of the pain can help differentiate this from trigeminal neuralgia. Lastly, other headache syndromes, such as SUNA and SUNCT, or giant cell arteritis, often can cause facial pain. Careful attention to autonomic symptoms, such as tearing, rhinorrhea, or meiosis, could help distinguish from these cephalgias. Likewise, the concurrent diagnosis of polymyalgia rheumatica should raise a red flag for giant cell arteritis. There are three commonly used classification systems for trigeminal neuralgia. The first is the Birchall Facial Pain Classification System. This is a purely clinical definition of trigeminal neuralgia and is most commonly used in neurosurgery. The International Association for the Study of Pain and the International Classification of Headache Disorders both have classification systems for trigeminal neuralgia. They do resemble one another, with small distinctions. Importantly, these two classification systems explicitly include imaging data or operative findings as a part of the final diagnosis. The Birchall Facial Pain Classification System seeks to characterize the most commonly seen facial pain syndromes in the neurosurgical clinic. Trigeminal neuralgia is distinguished from these other pains due to its spontaneous onset. The distinction between type 1 and type 2 trigeminal neuralgia under the Birchall system relates to the predominant phenotype of the pain. Type 1 trigeminal neuralgia consists of mostly episodic pain lancinating or triggered pain. Type 2 pain is more constant. It's called dull and achy by patients. Again, the presence of both types of pain is possible in either type of trigeminal neuralgia. The distinction rests on which pain the patient considers more significant. In contrast to trigeminal neuralgia, other types of facial pain result from trigeminal system injury. This can include neuropathic pain, which derives from unintentional trauma to the trigeminal nerve, trigeminal deafferentation pain, which occurs with intentional trauma to the nerve, symptomatic trigeminal neuralgia, which results from multiple sclerosis or a tumor, and postherpetic neuralgia, which follows a trigeminal herpes zoster outbreak. The International Association for the Study of Pain classifies trigeminal neuralgia as pain restricted to one or more divisions of the trigeminal nerve, being of abrupt onset and lasting only a few seconds. Patients can have continuous pain, which would change their diagnosis to trigeminal neuralgia with continuous pain. This classification system groups trigeminal neuralgia into classical, secondary, and idiopathic categories. Classical trigeminal neuralgia is associated with vascular compression, causing morphological changes in the trigeminal nerve root. This can be identified on MRI or during time of operation. Secondary trigeminal neuralgia is associated with other major neurological diseases. Idiopathic trigeminal neuralgia has no apparent cause. The diagnostic criteria for trigeminal neuralgia under the International Classification of Headache Disorders criteria are very specific. A patient must have 3 attacks fulfilling multiple criteria. These criteria include remaining within the distribution of the trigeminal nerve, having a paroxysmal character, severe intensity, a shock-like quality, and be triggered by innocuous stimuli. Patients must not have evident neurological deficits, nor other diagnoses that could account for their pain. The classification of trigeminal neuralgia is fairly similar to the IASP criteria. However, classical trigeminal neuralgia can have a purely paroxysmal subtype, in contrast to classical trigeminal neuralgia with concomitant continuous pain. The differences between these classification systems derive from 2 main sources. First, these classifications differ in how they handle the presence of constant persistent pain. Under the Birchall classification system, type 1 trigeminal neuralgia versus type 2 trigeminal neuralgia depends on the dominant pain phenotype. For the ICHD and IASP classification systems, the presence of any constant pain changes the trigeminal neuralgia subtype. Secondly, the ICHD and IASP classification systems incorporate the etiology of trigeminal neuralgia. These classification systems are based on imaging characteristics that reveal neurovascular compression or on intraoperative findings that reveal the same. The existence of multiple classification schemes begs the question of why it matters. Ultimately, classification of trigeminal neuralgia pain affects outcomes. Importantly, the pain phenotype and the etiology of trigeminal neuralgia both affect how patients respond to treatments. For example, the Long-term pain relief after microvascular decompression is very different between type 1 and type 2 trigeminal neuralgia. Patients with mostly constant, dull, achy pain do initially respond to microvascular decompression at a lower rate, and over time have less durable success. Likewise, comparing classical trigeminal neuralgia, or type 1 and 2 trigeminal neuralgia, to symptomatic trigeminal neuralgia, we see that patients with multiple sclerosis tend to have a higher impact on quality of life from their trigeminal neuralgia. Overall, they respond less to neurosurgical procedures. And finally, positive responses are not as durable as with primary or classic or idiopathic trigeminal neuralgia. We'll talk next briefly about the pathophysiology of trigeminal neuralgia. The majority of cases of trigeminal neuralgia are associated with neurovascular decompression. A branch of the superior cerebellar artery here can be seen compressing the trigeminal nerve, portia minor. This neurovascular compression is thought to cause injury to the nerve with the subsequent ignition of synchronized after-discharge activity from the affected neurons. This gives rise to pain paroxysms in response to innocuous stimuli. This ignition hypothesis is borne out by microelectrode studies in humans, where microelectrodes implanted in the trigeminal ganglion during radiofrequency procedures notes these paroxysmal discharges in response to stimulation at trigger zones and not at other sites within the trigeminal distribution. However, there are cases where there's no compression or distortion of the cranial nerve 5 by any vascular structures. These patients nevertheless have symptoms of classic trigeminal neuralgia. For example, here we see cranial nerve 5 and portia minor with no offending vessel within a reasonable distance. In fact, studies in patients with trigeminal neuralgia reveal abnormalities at multiple levels. These can include differences in gray matter. This can include differences in spontaneous brain activity, as measured using functional MRI, structural connectivity differences measured using diffusion tensor imaging, and electrophysiological differences measured using quantitative sensory testing. On a genetic level, there is evidence that genetic abnormalities exist in familial trigeminal neuralgia. And finally, at the level of sodium channels, we know that abnormal expression of NAV 1.7, 1.3, and 1.8 are altered in patients with trigeminal neuralgia. We'll talk next about non-surgical management of trigeminal neuralgia. Oral antiepileptics remain the mainstay of non-surgical treatment for trigeminal neuralgia. The gold standard is the dibenzazepine family with a greater than 90% initial response to therapy. The standard basic dose for carbamazepine is 200 milligrams a day divided into 2 doses, and likewise oxcarbazepine is 300 milligrams a day. Often these drugs are up-titrated to 4 to 6 times this standard basic dose. Side effects include cognitive impairment, changes in balance, and hyponatremia. Overall, these are intolerable in about 25% of patients. Other antiepileptics, such as gabapentin, Lyrica, and lamotrigine, are supported by limited evidence. Phenytoin is likely as effective as carbamazepine, although a head-to-head trial has never been completed. Importantly, phenytoin can be given IV, whereas carbamazepine cannot. There's little or no evidence for non-antiepileptic drugs in the treatment of trigeminal neuralgia. Baclofen, tizanidine, pimozide, and the sumatriptans have all been tried with little reason to suspect that they are effective. There's very little data on how to best manage acute exacerbations of trigeminal neuralgia. Some strategies include local anesthetic to trigger zones, subcutaneous sumatriptan. If these are not effective in 1 hour, an IV lidocaine infusion or IV phenytoin infusion can be performed. It is important to note that the last intervention is the only that could be potentially effective longer than 24 hours, and thus a longer-term strategy must be initiated. There is no evidence on what is most effective for trigeminal neuralgia type 2 or trigeminal neuralgia with concomitant persistent pain. In particular, the persistent pain is often refractory to the dibenzazepines. In general, treatment for this type of trigeminal neuralgia has been by analogy to other neuropathic pain syndromes consisting of gabapentin, Lyrica, and antidepressants. Lastly, we'll speak about the timing of surgical consultation for trigeminal neuralgia. In general, a multidisciplinary approach to the treatment of trigeminal neuralgia appears to have benefits. Prospective evaluation of structured management programs show that up to a 50% reduction in overall burden of pain is a reachable goal. Of note, management included early referral for surgery in up to 45% of these patients. In patient-centered evaluations of benefit, the medical management of trigeminal neuralgia has been found to offer the lowest expected trade-off between risks, side effects, and benefits. This, however, is by a slim margin. Studies such as this one imply that trigeminal neuralgia patients should be made aware of surgical options, even if they do not feel ready to pursue surgery or if surgical options are not appropriate for them. Again, patient reports suggest that overall satisfaction with surgery is very high. Importantly, the majority of patients often wish they had pursued surgery sooner. For example, in a comparison of microvascular decompression and partial sensory rhizotomy, patients were overall quite pleased with their outcomes, and again, 60 to 75% wish they had pursued their treatment sooner. Overall, trigeminal neuralgia is largely successfully treated with either surgical or non-surgical means. Medical therapy is successful in over 90% of patients. However, side effects are non-negligible. Likewise, surgical treatment is by and large successful. However, clinicians often overestimate success rates, underestimate recurrence rates, and side effects. All trigeminal neuralgia patients should consider medical and surgical options and be treated within a multidisciplinary group. Finally, the treatment of refractory trigeminal neuralgia remains a challenge. Many knowledge gaps remain with respect to recurrent trigeminal neuralgia and trigeminal neuralgia without neurovascular decompression, and future work is necessary to better delineate these subtypes of this disease.